Hello and welcome to the second part of the presentation on ACOs. Here we will look specifically at the Medicare Shared Savings Program, which is a program created under the Affordable Care Act aimed at stimulating the creation of accountable care organizations. We will look at what this program entails, but we will also consider it as a case study in the administrative rulemaking process, something that we covered way back in the first lesson of the class. In the last presentation, we looked at the idea of ACOs at a conceptual level. Now let's take a look at a policy initiative included in the ACA aimed at helping providers adopt the ACO model. And just to be clear, the Affordable Care Act, also known as Obamacare, was a big piece of legislation with numerous provisions. And the central and most controversial aspects of the ACA relate to increasing access to health coverage through insurance marketplaces, mandating individuals to carry insurance, and expanding Medicaid. In this presentation, I'm not going to talk about those aspects of the ACA. Rather, the ACA also included a variety of smaller pilot programs aimed at addressing the cost and quality of care. And the MSSP, the Medicare Shared Savings Program, is one of these. So the goal of the MSSP was to create an initiative for providers to form The goal of the MSSP was to create incentives for providers to form ACOs so the ACO value-based payment model could be replicated through agreements with private insurers as well. So even though the MSSP relates only to Medicare patients, that is, those typically 65 years and older, the idea is that if providers go to the trouble of creating an an ACO to participate in the MSSP, it can then enter into similar shared savings ACO agreements with private insurance companies for other categories of patients. And there is historical precedent for the government using the Medicare program as a way to achieve policy goals beyond just Medicare patients. For example, EMTALA, the Emergency Medical Treatment and Active Labor Act, requires all hospitals who participate in the Medicare program that have an ER or emergency room to treat emergency patients regardless of the patient's ability to pay. And back in the 1980s, Medicare began paying for inpatient hospital services through bundles called diagnostic related groups. And then private insurance companies began billing for services in the same way. So the MSSP was created in Section 3022 of the Affordable Care Act, and it is a whopping 4.5 pages long, or just 2,072 words. And by comparison, the Affordable Care Act as a whole contains over 380,000 words. And in the 2,072 words creating the MSSP, the statute just lays out the general parameters of the program, and then the United States Department of Health and Human Services, the federal agency that houses the Centers for Medicare and Medicaid Services, has the authority, it delegates to this agency, the authority to create administrative regulations that fill in the details. So let's first look at the general parameters of the MSSP under the statute itself, and then we'll look at the regulations. So the statute directs HHS, or the Department of Health and Human Services, to create a program where Medicare Part A and Part B providers may work together to manage and coordinate care for Medicare patients through an ACO. So the statute actually uses the term ACO, or Accountable Care Organization. And Medicare Part A covers hospital care, so this refers to hospitals, and Medicare Part B refers to physicians and outpatient services. And the objective is that through this coordinated care, the ACO will bring savings to Medicare. That is, Medicare will pay less than it would have in the absence of the ACO. And the statute states that the ACO, if it meets quality performance standards that are going to be created by HHS, the ACO will be eligible to receive payments for shared savings, hence the name, the Medicare Shared Savings Program. And the statute states that the purpose of the MSSP as follows: promoting accountability for a patient population, coordinating items and services, and encouraging investments in the infrastructure and process for efficient care. So this is where you see the aim of the MSSP, is for providers to create ACOs that can contract with private insurers as well. The statute lays out some general rules as to how an ACO can be structured under the MSSP in order to participate in the MSSP. First, the ACO must be responsible for at least 5,000 traditional fee-for-service Medicare patients. So Medicare patients enrolled in a Medicare Advantage plan cannot count towards these 5,000 patients. And these 5,000 patients is calculated by primary care claims data. So if an individual has Medicare billings claim for a primary care physician that is part of an ACO, that patient is part of the at least 5,000 patients that are included in this ACO population. And the patient can change his or her primary care provider if he or she does not want to be part of the ACO. And the statute provides a lot of flexibility in terms of how an ACO can be structured. Nothing in the law requires that an ACO consist of hospital and group practices that are owned by the same organization. And the hope here is that providers in regions where they are not highly integrated will opt to create ACOs. Specifically, the ACOs can consist of a variety of structures, including health professionals and group practices, networks of individual practices, a partnership or joint venture between hospitals and individually employed ACO professionals. And so this would include primarily physicians, but may also include dietitians, physical therapists, occupational therapists, mental health professionals, and other professionals involved in the care of Medicare patients. The structure could also include hospitals that employ ACO professionals. And then the statute finally provides a catch-all for other groups of providers as approved by HHS. So the idea is there is a lot of flexibility as to how an ACO could be structured. And finally, the statute requires the ACO to commit for 3 years. And then they can either renew or not continue with the program. As the name of the program indicates, there is a shared savings incentive for reducing costs. If an ACO reduced Medicare spending while achieving specific quality standards, an ACO gets a share of the savings If an ACO reduces Medicare spending while also achieving specific quality standards, the ACO will get a share of the savings that it brought to Medicare, usually 50 to 60% of these savings. And the savings are calculated based on a per capita benchmark that is generated using past spending trends. So as an example, let's say you have 10,000 Medicare patients that get assigned to an ACO, and the benchmark average annual Medicare spending for each patient is $11,000. If the ACO can reduce that average to $9,000 per patient, this will save Medicare a total of $20 million. 10,000 patients times this $2,000 in reduction per patient equals $20 million. Under the MSSP, the ACO would get about 50% of that share of savings, or $10 million, if the ACO also meets quality standards. So this $10 million shared savings bonus payment would be the financial incentive to provide high quality and cost-effective care. Of course, the 2,072 words creating the MSSP that are created in the statute leave a lot of unanswered questions. For example, how is the benchmark to be established? So if you say that the average per capita spending is $11,000 per patient or $10,000 per patient, how exactly do you reach this amount? How do you account for inflation or growth in health spending between the benchmark year and the present? For example, let's say an ACO is more efficient in providing is effective in providing efficient care, but the cost of drugs and medical devices also go up because of inflation. How do you account for that? And also, let's say the population is getting older, which it is. So that means people are likely to get more complicated care as time goes on. So even if the ACO is providing more effective care and more cost-effective care, its overall spending may not fully reflect this because its population of Medicare patients is now older. So how do you account for this? Or also, if you have an ACO, a group of providers that form an ACO, and prior to creating the ACO, they were already efficient in providing care, and they thus have a lower benchmark. How do you account for that? And there are ways that actuaries and managerial epidemiologies can adjust and account for all of these factors, but it needs to be clear how they are going to do this. Also, the MSSP says that it will track quality based on standards to be created by the Department of Health and Human Services. Well, what are these standards? How will it occur? What data points will be used? And how will the information be collected? And how high of a quality of score is considered passing? Will it be incrementally graded, or will it be kind of pass-fail? So please keep in mind that these and other issues are details that need to be filled in through the administrative rulemaking process. And that's where the administrative rulemaking process comes into play. This is something we covered way back in the beginning of the course. So now I want to look at the creation of the final MSSP regulation or administrative rule as kind of a case study in the administrative rulemaking process. And keep in mind the term regulation and administrative rule are synonymous in this context. They mean the same thing. By way of review of the administrative rulemaking process. So Congress, if it's a federal law, or a state legislature, for state laws, they will enact a statute. And if the statute involves the creation of a specific program, such as the MSSP, it will typically grant an administrative agency the rulemaking authority to implement the program created in the statute. Here, the Affordable Care Act created the MSSP and delegated authority to HHS to create administrative rules filling in the details on the program. And the rulemaking process varies depending on the circumstances, but it typically involves issuing a proposed final rule, allowing public comment, usually for 60 days, and the comments will generally just be submitted in writing, but for some major issues that involve a lot of public interest, such as environmental regulations, the agency will also hold public meetings to receive comments and may extend the comment period for longer. And then the agency will review all of these comments, and depending on the issue, there may be hundreds or thousands of these comments. And the agency doesn't need to respond to every comment individually, but it does need to respond to every substantive issue raised in the comments. Many comments will raise the same issues, and each issue only needs to be addressed once. And then the agency may make changes to the proposed rule based on the public comments and then issue a final rule. And here's a timeline of how this occurred with the MSSP. So in March of 2010, Congress passed the Affordable Care Act and President Obama signed it into law. Buried way down in section 3022 are the 2,072 words creating the MSSP that we just talked about. And then in March of 2011, HHS issued its proposed final rule and received public comment during that summer. There were a total of 1,320 comments. Most of those comments would have come from healthcare providers possibly considering creating ACOs, but also included input from consumer advocacy organizations such as AARP. And then HHS took the feedback into account and made revisions, issuing a final rule in October of 2011. And in doing so, HHS also issued a very lengthy document, 189 pages of 9.3 column single-space font, responding to comments and explaining the reasons behind its revisions. They also provided the reasoning for not incorporating some of the recommended changes presented in public comments. So let's take a look first at the features of the proposed rule issued in March 2011, and then we'll look at the changes made in the final rule. Recall that the statute said that ACOs would enter into a 3-year agreement with HHS. Regarding the shared savings amount, the proposed rule said that in year one and two of this 3-year agreement, the provider would get 50% of any savings if the spending comes under the benchmark. And then in year 3, the ACO could get 60% of the savings, but during the 3rd year, the ACO would have to pay a penalty to HHS if spending exceeded the benchmark. So it created a lot of risk for the ACO during this 3rd year. And in terms of quality tracking, the proposed rule said that there would be 64 different measures of quality, and that the shared savings amount would be tied to the ACO's grade on these 64 quality measures. So for example, if an ACO achieved 80% of the quality measures, they would only get 80% of the shared savings payment. So it was not a pass-fail model, and there would be more risk involved for the ACO. So in the comments that the health industry submitted during the summer of 2011, what was the reaction? Basically, they said that it was too complicated and too risky. The title of this article from the Health Affairs blog highlights the reaction. Overweight and out of shape ACO regs need a major makeover. So let me give you an analogy that illustrates the reaction of the healthcare industry to these proposed regulations. Let's say that Boise State is going to offer an elective class on a topic that is very interesting to you. And before enrolling in the class, the professor emails the syllabus. And the syllabus says that there are going to be 64 exams over the course of the semester. And let's say that the professor says that she is a member of the fictitious American Society of Professors Against Grade Inflation, and that as a result, she will give no more than 2 A's in the entire class, and that at least 70% of the class will get a C or below. Would you enroll in that class? Probably not. And that's what the health industry told HHS about the MSSP program. They said that the MSSP program is a voluntary program, and we are not going to do it if it is this complicated and risky. And HHS took this feedback into account and made several major changes to the final rule. First, HHS simplified the risk model. Specifically, HHS created an option for new ACOs to receive 50% of the shared savings for all 3 years without the risk of having to pay a penalty if they exceeded the benchmark during the 3rd year. HHS also simplified the quality tracking from 64 measures to only 33 measures. And they created the quality standards, and they changed the quality standards to essentially a pass-fail model, where providers would be deemed to have met the standards if they achieved 70% compliance during the early years. And during the first 2 years, some standards would be deemed as met for just reporting the data. They weren't worried about what the scores were. They just wanted providers to get into the habit of tracking and reporting that data. And finally, HHS created an advanced payment option, which is essentially a loan on the anticipated shared savings bonus to allow the ACO to cover some upfront costs of creating the ACO, such as hiring care coordinators, adopting electronic health record systems, and entering into agreements with providers. So here's a bit more on the quality measures. 33 quality measures were established within two broad domains: better care for individuals and better health for populations. And as you can see, the final rule creates a pass-fail system for meeting 70% of the quality measures within each domain and simplifies the reporting process. Here are some examples of the quality measures related to patient experience and patient satisfaction. And you see questions like getting timely appointments, access to specialists, communication with patients, and rating the patient's doctor. So the aim here is that these measures are targeted at some of the concerns with HMOs, such as gatekeeping to see specialists, difficulty getting an appointment, and patients being forced to go to a doctor they didn't like. And this information is collected through either surveys, or claims data. And you see the R under the column for year 1. That means that the provider is deemed to have met this standard in the first year by just reporting this information. The idea is they want to get providers into the habit of tracking this information. And this gives the providers a bit of time to fix things before their performance will be tracked during years 2 and 3. You see the P for performance. And here are some other examples of the quality measures targeted at specific risk populations, or at-risk populations: diabetes, hypertension, cardiovascular disease. And I'm showing this to illustrate how proven evidence-based practices are built into the quality measures in the MSSP program. So that is the Medicare Shared Savings Program as implemented in the administrative rules. Well, I should say it's just a snippet, but a summary of how this worked. In the next presentation, we will look at how successful ACOs have been and the program In the next presentation, we will look at how successful the program has been and the future prospects of ACOs. Thank you for your attention.